are listening to the Addiction Files, where we discuss evidence-based treatment, clinical pearls, and resources while striving to destigmatize the treatment of addiction in our medical culture and save lives. We are the Addiction Doctors, Dr. Darlene Petersen and Paula Cook. Welcome to the Addiction Files. We are back with another fantastic episode. We are discussing a really interesting trend, and this is about the initiation of buprenorphine in the light of fentanyl. So this was a study that came out that was funded by NIDA, and this is titled Buprenorphine Dose and Time to Discontinuation Among Patients with Opioid Use Disorder in the Era of Fentanyl. This was published in JAMA Open Network in September of 2023. And this was from Chambers, Hallowell, Zullo. This is what we would call a retrospective study, and this was looking at patients in Rhode Island. And it was a pretty large study looking at 6,499 patients. There was not actually any patient contact. This was a review of prescription monitoring database. And they looked at doses of 16 and 24 milligrams. And we'll go into more detail of the study design and a little bit later, which is helpful, I think, to understand the type of the study and why some of their methodology. But I think it's important, Paula, first, let's just kind of back up and just talk about first, why is higher doses being proposed for fentanyl in the first place?
We know obviously fentanyl, we're all well aware of the overdose, increase in overdose deaths nationally. And, in 2021 reported to be 107,000 people, and more than 70,000 of those were primarily due to fentanyl. So it's a huge problem, and it's got unique properties because it's highly potent synthetic opioid. And it's causing really high tolerance in people and kind of rapid physiological dependence. And we're seeing this clinically. I see this all the time. People start using fentanyl, and they say that just even within a few doses, they feel completely hooked and they have to use more and more and use again and again. So there's a very steep curve to physiological dependence and, substance use disorder with fentanyl. And it looks like there's some theories as to why that is so beyond just its potency. And you were just talking about this before we started, Darlene. You want to talk about that?
Yeah, and this is really interesting, and this comes directly from the study. There were some theories in kind of their preclinical studies that have suggested the method of how fentanyl works, of why we're having such difficulty with this. Is fentanyl itself, the synthetic opioid, downregulates the mu-opioid receptor. So I'm just taking this as a direct quote. And so when it does that, it leads to this downregulation of that mu-opioid receptor to a much higher degree than morphine. And then that's what increases that tolerance that you're talking about. So it induces greater tolerance to its effect. And what we would do is, assuming that data, is that it would predict higher doses of partial agonists like buprenorphine would be needed to substitute for fentanyl than what would be previously, when all of our previous studies were always with opiates like morphine and heroin. And so we don't have that. And that's where we came up with all of our other studies previously. We're always using the morphine and heroin. And so that's where we came up with those dose recommendations between 8 to 16 milligrams. And so when we're now using with this new synthetics that are having this different effect on that opioid receptor, now we are looking at this as something that is going to possibly require a much higher dose of a partial agonist. So some of the methods in this study, this was interesting. So when we're looking at just provider monitoring databases, we know that's not going to include prescriptions that are coming out of the hospital, and it's not going to include OTP. So they did point that out, that that's going to be a little bit of a design flaw there. But this does, and the only data that they are able to report on is the typical demographics that you would see from the patient. So you have, obviously, you have the address of the patient, you have male or female, and you have age. And the other thing that was interesting, and they did look at this, was the patient's address and the address of the pharmacy, and they split it into how close they were to the pharmacy. So less than 5 miles or greater than 5 miles from the pharmacy, to see if that had any kind of effect on retention too. So the study took place they looked at data from October of 2016 to September 2020. And why the 180 days? So what were we looking at? This is from the study. The goal was to estimate the association between a patient's daily buprenorphine dose and the retention and treatment over 180 days. And that time frame came from the minimum treatment period considered by the U.S. Centers for Medicare and Medicaid Services to measure treatment continuity for an opioid use disorder. So it's not that that's necessarily magic, but that's just coming up with that standard. And then a gap in care, what they defined as a gap in care was when you have 27 days based on prescription fill dates and days supply. And let's review some of the findings, Paula. So let's go into that a little bit more. So what was some of the things that they found, Paula? So some of the, as far as like demographics of the patients that they ended up finding, and difference between the dosing, what did you see there?
Well, most patients were male and aged 25 to 44, and Medicaid was the most common payer in this group. And they found that what they considered lower dose buprenorphine, which was 16 milligrams or less designated in this study, was associated with 20% more discontinuation in treatment compared to the 24 milligram group. So when you look, the raw data was 59% of those prescribed 16 milligrams of buprenorphine discontinued treatment. So there's not continued retention at 180 days, versus 53% of those prescribed 24 milligrams were discontinued in treatment within 180 days. So they performed a statistical multivariate analysis saying that difference between 59% discontinuation and 53% discontinuation of the 16 versus 24 milligram buprenorphine group is actually statistically significant. So there's a 20% difference in discontinuation and treatment, which is quite significant, really, when you think about the odds of people not continuing in treatment. I mean, when people don't continue in treatment, the risk of, morbidity and mortality is quite significant. One thing and then they also found that the higher dose, so 24 milligrams, was safe and well tolerated. That's what they said about that. So there was not as many adverse effects reported from the higher dose compared to the lower dose. So it's interesting because we've gone back and forth over the years, especially since the beginning of buprenorphine for opioid use disorder, which both you and I, Darlene, were around for in 2003, how we've kind of traveled this journey with this drug, looking at its unique properties of partial agonism and high affinity for the mu opioid receptor, making it a non kind of dose dependent medication where it seems to have maxed out its benefit at a dose of 16 to 20 milligrams. And so now the study anyway found that there's a 20% discontinuation delta between those prescribed 16 versus 24. So what do we make of that? And I think you have some comments about the methods of this study and the limitations based on the fact that it's just a longitudinal review. And we need to see how carefully we can extrapolate the findings. One thing that's just aside that I wanted to comment about is despite the dose of buprenorphine 16 versus 24 milligrams, continuation or discontinuation in treatment at 180 days for opioid use disorder was 59% for people on 16 milligrams of bup and 53% on those prescribed 24 milligrams of bup. That's a lot of people. That's more than half the people weren't in treatment at 6 months, even with the best treatment we have available. Buprenorphine and methadone are equally as good as each other. And that's pretty much what we've got, right? We're going to talk in a minute about what else improves retention and treatment, but we're looking at a really serious, chronically relapsing, deadly condition, opioid use disorder. And even with our best treatment, we have over half of the people leaving treatment in 6 months. So I just wanted to comment on that it's better than the alternative, which is no medications, which the discontinuation rate is much higher. It's in the 90 percentile range. So we have a much improved retention with medications, but I still think we have a long way to go. Anyway, that's just an aside.
I couldn't agree more. It's just showing that the problem is still there, that we really are quite overwhelmed by these emerging drugs that are coming, that we're seeing out on the street, that we're having such a hard time. They're overwhelming the medications that we have. That's what I think we're experiencing and why we're having these conversations. But yeah, I mean, back to your question that you were alluding to, Paula, so what are some of the limitations? And the author did discuss some of those. And then Paula and I, we were having this discussion before we started and talking about who's going to take which side. But I think we both agree. And for full transparency, I feel like sometimes you feel a bit sheepish because I can just hear myself okay, if giving a lecture 10 years ago, even 5 years ago, we were just taught this party line of, okay, this receptor is 93% saturated at 60 milligrams, and really you don't need to go above 60 milligrams, and insurances wouldn't pay. I mean, I don't know which was what was guiding us more sometimes, right, Paula? But that's what we would teach. And we have all said that, and that's how we've practiced for years. But the substance use, and when you're seeing this, and still I want to make it very clear, this is not something that we are saying for all substances. You may still encounter patients coming to you on different substances, and you're not going to induce them with these what we call macro dosing amounts, because it's like Paula's talked about. Sometimes you have these little old grannies that come in here on their Lortab, 4 to 6 times a day, but it's quite problematic for them and they need to come off. You're not going to put them on 24 milligrams of buprenorphine. They may not even tolerate 6 milligrams of buprenorphine. So that's not what we're saying by any means. We're not changing it. But when you are using synthetic opiates, this is when you're having challenging inductions. This is where this trend is going. And that's what these studies are looking at. Is this a solution? That's what this study is suggesting. So some of the issues and some of the limitations is one, when this is the first thing.
I just want to say something too. I mean, the other thing, Darlene, is I agree with you. I mean, I have slide decks and talks that I've given, and we've even given content at the beginning of the podcast season 1.
Absolutely.
That we probably need to go back and adjust, but we haven't always been right. You know, and we're not right now either. So we're dealing with a condition that has, 50% failure rate in treatment, even with the best medication we have. I mean, we're still figuring it out. And I think that's the thing is I had a conversation in my treatment team meeting today, because I have a patient who's using fentanyl, really high doses of powdered fentanyl. We're trying to stabilize her on her methadone dose. We've kind of made it a clinic policy to not increase methadone doses, and people are having AWOLs during the week, and yet she can't stabilize because she's having so much withdrawal that then she's not coming to clinic because she's still using. And so do we increase the dose? And so I basically had to go back on my word, and I changed what I had said last week in treatment team meeting. And I think things are just continually shifting, and we need to rely on the data to help guide us. And that's why I'm so grateful that we have these ongoing studies to keep investigating what really is helpful for people, because we still don't know. And I think we need to be flexible and open-minded, and instead of being like, well, we never prescribe more than 16 milligrams, or well, everyone should get 32 milligrams. I think we need to really realize that we're addiction medicine, much like neurology and psychiatry, they're kind of the frontiers, because we're dealing with the brain and we just don't know, and we have to.
That we don't ever say everyone gets 16, everyone gets 32, but both of us have ran into prescribers that every patient came into practice was given either the same dose of everything. And just what I brought up before, some patients, 6 milligrams is appropriate or 8 milligrams is appropriate. And then your next patient that you see, that you walk into the room, 24 milligrams might be appropriate.
Sure, it's personalized, just like everything.
Exactly. But that's what I think this is showing, that we need to be very thoughtful, and you need to take very careful histories. And it's just like what you see, and you need to work with your treatment team. What are we really seeing? What are they really using? And get those really careful histories. And make your decisions based on that. And then also the patient's response to treatment too.
Right. It needs to be patient-centered, and every patient's different. And
yeah,
absolutely.
And so that we can definitely reach our patients. It's like you said, they're not coming in, but they're not, if the treatment's working, they come back. If the treatment's not working, then we're losing our patients. So we've got to figure out, what can we do to reach our patients? So I think that's really important. But some of the limitations, like obviously we know what the patient was dosed, but we don't know what the patient actually took. And that's where Paula and I sometimes differ a little bit, but we don't have the data on the compliance, and we don't know the diagnoses per se of what they were using it for. They using the films and tablets. They excluded the films that are prescribed. So this would be the brand name Belbuca that most people are familiar with, that is FDA approved only for pain, or the patch, the Butrans, that is FDA approved only for pain. But interestingly, sometimes that's used for buprenorphine inductions, so off-label. But those were excluded in this study to try to just get that data, just to look at. So we have some of the limitations is we don't know what was the diagnosis and what was the compliance. We just know retention. These are how many times they went and filled. Mm-hmm. And so some of the limitations when you don't have control, that's why you need a study where the medications actually you're controlling for dosing the medication, and you have some compliance and information there. Those are the limitations. The interesting thing that they talked about is you had this, it completely matched as what they talked about is you saw the first early data, you saw less doses of the 24 milligram. But then as you saw an increase in fentanyl use, you saw more 24 milligram. It's not that they didn't see higher doses than 24 milligram, but there wasn't enough data to get enough to be able to use that consistently. But it's also that frequently payers limit that. And so it's hard to use that as accurate data, because it doesn't mean that wouldn't have been beneficial, but is it just not being prescribed because it wasn't necessary or it wasn't being allowed? Does that make sense?
Mm-hmm. Yeah,
So,
it does.
That's why there was a little bit of that information of that's why that dose, why they just focused on those 2 doses. But these are some future areas that need to be studied. And the authors talked about that this is just to get the conversation starting and to get the information out there that we really maybe need to start looking at some of these dosing options and like Paula said, individualizing our treatment plans. And hopefully more data is going to come, which will make it easier for us to prescribe. But I really do appreciate the study. I don't want to make it sound at all negative. I do appreciate the study because I think that also helps us for the times, because I still get pushback sometimes when I've had patients where you need to move up to 24. I do get pushback from payers that won't pay for doses above 16 milligrams. And I think that still happens. And I don't think that's only in our state. So I think that's interesting. And then Paula, we talked about this. So retention and treatment, there's 2 interesting studies that you brought up. Do you want to go into those some more that talk about how do we, and this is what the authors really didn't go into because we can't really interpret that data out of this, but what factors and what do we know about retaining patients in treatment?
Right, because this study just looks at dose of buprenorphine, but what other strategies do we have for retaining folks when they're taking medications for opioid use disorder? So there is a rapid evidence review that was published in the Journal of Addiction Medicine in 2021. The primary author was Brian Chan. And they searched Medline and the Cochrane Library from 2009 to 2019, so over a 10-year period. And they looked at, care setting services, logistical support, contingency management, IT, different formulations of buprenorphine and naltrexone, actually, psychosocial interventions and assessed retention at least 3 months. So they ended up looking at 2 systematic reviews and 39 primary studies. Some of them didn't look at retention as the primary focus, but what they did find is that there were some things that emerged out of all of this review. So, and these are some key points I think they're good to take away. So, number 1, initiating medications for opioid use disorder in soon-to-be-released incarcerated people improved retentions following release. This makes so much sense. I mean, we have a really, really high-risk population, incarcerated people. When they leave, they're at the highest risk of all people in terms of overdose and death and reusing opioids. And so if we initiate medications for opioid use disorder before they're released, they're more likely to be retained. And that includes buprenorphine, methadone, and naltrexone. They looked at contingency management and they found that it may improve retention, but only in the group that was using naltrexone, not buprenorphine or methadone. So that's interesting. I'm not sure I've ever heard that before, so I'd be interested to track that down. And why contingency management worked in the naltrexone group and not in the agonist group. But
it would be interesting to look at the methods of if patients self-selected.
Right,
like because the patients that I find who are usually on the naltrexone are very motivated for kind of like they feel like that's their abstinence. And so they're really motivated. And if they somehow kind of self-selected, but it should be, you would think if it was a study that was randomized, but yeah, I'd have to look more closely at that study.
Right. And we find that retention is pretty comparable if we look at extended release versus daily buprenorphine. So it's pretty much the same in this population, in these reviews. And there's not similar retention when we look at extended release naltrexone versus daily buprenorphine. So with opioid use disorder, we're not talking about other substance use disorders. Buprenorphine is superior to extended release naltrexone. And we think that we've talked about this before, but we think this has a lot to do with the fact that an agonist at the opioid receptor makes all the difference. And then what is always really interesting, and this comes up time and time again, is most psychosocial interventions, even though we insist on them, they're part of the federal rules, they're part of OTP guidelines. We write that patients need to do this, but most psychosocial interventions when it comes to OUD do not improve retention. So that's an interesting study. I think it's good to refer to that, and we know what improves retention and what doesn't.
Yeah, I think that's great. It's not that our patients don't benefit from psychosocial interventions, but it's like what you said, it's not stopping it's not reducing overdose is what another study showed, and it's not improving their retention and treatment. Okay.
Right. So a thing to think about when it comes down to this is we're not discounting psychosocial treatments. We're not discounting the value of therapy or groups. But when it comes to providing access to treatment and it comes down to just getting people on medications, that is the primary goal. We should not make therapy and counseling necessary and required and discharge patients or refuse to give them medications when they won't participate in psychosocial treatments, saying that they should, because the evidence actually shows that it doesn't improve retention. Now, it may improve individuals' retention. Absolutely. Everyone has a different response to treatment. But overall, these antiquated ideas that people must participate in psychosocial interventions have been discredited. Right. And then there's another study, and this is a little bit more of a niche population, but again, I just thought I'd bring it up. This was a study that was released in JAMA Open Network in September 2021, and the author is Joshua Lee et al. And he looked at comparison of treatment retention of adults with opioid addiction managed with extended release buprenorphine versus daily single buprenorphine naloxone at the time of release from jail. So this is an interesting question. I think those of us who are working with patients with opioid use disorder, we wonder all the time, like, is extended release buprenorphine versus daily better? Well, we just heard from the previous study that retention is similar for both. However, when it comes to folks who are being released from jail, if we give them extended release bup versus daily sublingual bup, what is the outcome? So this is an open label randomized effectiveness study. It looked at 52 incarcerated adults in New York City, so not a huge study. It observed them for 8 weeks post-release in 2019. And the main outcomes were buprenorphine treatment retention at 8 weeks. So they offered extended release buprenorphine prior to release and continued monthly through the 8 weeks after release. So probably just one more injection after they were released. And they also offered sublingual buprenorphine to the other group, and they received daily directly observed in jail sublingual administration. And then they were provided with a 7-day sublingual buprenorphine supply at jail release, and then follow up at a designated clinic. And what they found was that between the two groups, the community buprenorphine treatment retention at week 8 post-release in the extended buprenorphine group was 69.2%, which is actually pretty good, versus 34.6% in the daily sublingual group. That's right. So quite a significant difference there. Now, I have a comment about that, but they also looked at rates of opioid negative urine tests. And in the extended release buprenorphine group, opioid negative urine tests were found in 55% of the follow-up group versus 38.4% of the sublingual group. There was no difference in adverse effects or overdoses or deaths, but that's pretty significant difference between extended release and sublingual buprenorphine. What I wonder about is if they had given the sublingual buprenorphine folks enough medication to get them through the 8 weeks, if it would have had different outcomes, but they gave them 7 days and then a referral to a designated clinic. I'm just wondering how many actually, how much that affected people, because we all know that that gap in treatment or that transfer can be so difficult for people. But
especially high risk groups,
right?
Yeah, I agree. Like, it's very difficult to get that data because when you try to remove continuity, and that was a thing I didn't bring up before. When you're just looking at the data, like we can't talk about retention treatment. Like, how many of these were these just initiation in some clinic, and then were they allowed to? Is the continuity affected by exactly what you're talking about? that this was just somewhere where they were maybe starting in a treatment program and then transferring, and that wasn't supposed to be long-term. And that's what's affecting some of this.
Mm-hmm.
You
Yeah.
know? But
And it's also,
that's a common issue, like.
Right. It's a common issue. Or is this particular population much more responsive to extended release buprenorphine in terms of all the other things they have to deal with when they get out? Mm-hmm. Rehousing, reintroduction to society, dealing with fines, dealing with AP&P, and that extended release buprenorphine just makes much more sense than giving them daily buprenorphine and expecting them to go to a clinic every week or every day if they're an OTP, or every month even. Mm-hmm. So like, I work in a jail. I found this study very interesting. What I want to know is, how do we get patients extended release buprenorphine on release?
I'm going to tell you,
the magic question.
That is the magic thing, because
no one pays for it.
I deal with a similar population and I can't get them either.
To pay for it. Yeah. You deal with the prison release patients. So anyway, in retention for patients who actually get the medication, that's the number one takeaway. Patients are retained if they get the medication. Maybe higher dose is better in the age of fentanyl, 24 milligrams versus 16. It looks like there's probably according to this study, 20% difference. And then other things that improve retention are, maybe contingency management if they're on naltrexone, not psychosocial things, and then initiating MOUD in people soon to be released from incarcerated settings, and consider extended release buprenorphine for those folks versus daily.
Well, and I would just add, from our experience, the extended release buprenorphine for any kind of unstable populations in general, we have found that can be very stabilizing for those who have difficult psychosocial circumstances, those who suffer from homelessness. That can be very stabilizing for them. So I would add that in there, but we use it in lots of different patient populations, and it can be very helpful and improve that retention. And that's what they didn't include in this study, but that can be something. But this was a little bit different. That's a little bit different. We're just talking about retention. But it was interesting. Very interesting points and very interesting study. Thanks, Paula.
Thank you. Have a good night.
Until next time. Hey, check us out at theaddictionfiles.com or email us at theaddictionfiles@gmail.com. Thank you so much to Ricky Valades for use of his song Awake. Check him out at rickyvalades.com.
Are for entertainment and education purposes only. Hosts and guests are not responsible for any harm caused by information obtained from this source. As each person is unique, you're advised to seek the advice of your own healthcare professional to treat any medical conditions you may be having. Opinions expressed on this show are those of the Addiction Files and not of our respective employers.